Question 1. The efficiency study reveals that a rapid and accurate physical examination is paramount in the initial management of burn patients. Considering a patient presenting with significant thermal injury and potential for associated trauma, which approach to the physical examination best aligns with advanced burn life support ABLS certification principles for assessing burn extent and depth, while also accounting for other critical injuries? Option A. Head-to-toe assessment that systematically evaluates airway, breathing, and circulation, followed by a detailed assessment of burn depth and extent using standardized methods, and a thorough search for associated injuries. Option B. A focused examination of the burn areas to estimate size and depth, with a brief visual scan for obvious external trauma, deferring a comprehensive assessment until the patient is more stable. Option C. An initial assessment prioritizing the patient's pain management and comfort, followed by a less detailed estimation of burn size to guide fluid resuscitation. Option D. A reliance on the patient's verbal report of the incident and visible burn areas to determine the extent and depth of the injury, without extensive physical probing. Correct answer is A. A head-to-toe assessment that systematically evaluates airway, breathing, and circulation, followed by a detailed assessment of burn depth and extent using standardized methods, and a thorough search for associated injuries. Explanation. Scenario analysis. This scenario presents a professionally challenging situation due to the critical need for accurate and rapid assessment of burn extent and depth in a patient with potential associated injuries. Misjudging the severity can lead to delayed or inappropriate treatment, significantly impacting patient outcomes and resource allocation. The presence of associated injuries further complicates the physical examination, requiring a systematic approach to avoid overlooking life-threatening conditions. Correct approach analysis. The correct approach emphasizes a systematic and thorough physical examination, prioritizing airway, breathing, and circulation, ABCs, while concurrently assessing burn severity and identifying associated injuries. This aligns with advanced burn life support ABLS principles, which mandate a comprehensive evaluation to guide immediate management and resuscitation. Regulatory frameworks and ABLS guidelines stress the importance of a head-to-toe assessment, including detailed evaluation of burn depth, superficial, partial thickness, full thickness, and extent, using tools like the Rule of Nines or Lund-Browder chart, as well as a diligent search for other trauma. This systematic approach ensures that all critical aspects of the patient's condition are addressed, leading to optimal patient care and adherence to established protocols. Incorrect approach is analysis. An approach that focuses solely on the burn area without a comprehensive assessment of ABCs or associated injuries is a significant regulatory and ethical failure. It violates the fundamental principle of prioritizing life-sustaining functions and can lead to overlooking emergent conditions like inhalation injury or internal bleeding, which are often associated with severe burns. This narrow focus is contrary to ABLS guidelines and best practices in emergency medicine. An approach that delays a detailed burn assessment to address less critical issues first, without a clear clinical rationale based on ABCs, is also professionally unacceptable. ABLS protocols require prompt estimation of burn size to guide fluid resuscitation, a critical intervention. Delaying this assessment can lead to under-resuscitation, resulting in burn shock and organ dysfunction, a direct failure to provide timely and appropriate care as mandated by ABLS. An approach that relies on assumptions about burn depth or extent without direct visual inspection and palpation is ethically and regulatorily unsound. ABLS certification emphasizes the importance of accurate physical examination skills. Guesswork or reliance on incomplete information can lead to misclassification of burn severity, impacting treatment decisions, such as the need for escherotomy or surgical intervention, and potentially causing harm to the patient. Professional reasoning. Professionals should approach burn patients with a structured, systematic methodology. This begins with immediate ABC assessment. Following stabilization of ABCs, a detailed physical examination for burn extent and depth should be performed concurrently with a search for associated injuries. This involves using standardized methods for estimating burn surface area and classifying burn depth. Documentation of findings is crucial for ongoing care and communication. In cases of significant burn injury or associated trauma, a multidisciplinary approach involving burn specialists, trauma surgeons, and critical care teams is essential. Continuous reassessment is vital as the patient's condition can evolve rapidly. Question 2. Consider a scenario where a patient with a partial thickness burn on their forearm expresses a strong preference for a specific over-the-counter topical ointment they have used successfully for minor cuts in the past, despite the clinician recommending a silver-impregnated dressing for optimal antimicrobial coverage and moisture balance. The patient insists on using their preferred ointment, stating it feels more comfortable and they are concerned about the chemicals in the recommended dressing. Option A. Immediately apply the patient's preferred over-the-counter ointment as requested to ensure patient satisfaction and avoid conflict. Option B. Suggest a trial of the patient's preferred ointment for 24 hours and then reassess the wound without further discussion of the recommended dressing. Option C. Gently explain the rationale behind the recommended silver-impregnated dressing, detailing its benefits for burn wound healing, including infection prevention and moisture management, and discuss the potential risks of using the patient's preferred ointment, such as delayed healing or increased infection risk, before collaboratively deciding on the best course of action. Option D. Inform the patient that their preference cannot be accommodated, as it deviates from standard burn care protocols, and proceed with applying the silver-impregnated dressing. The correct answer is C. Gently explain the rationale behind the recommended silver-impregnated dressing, detailing its benefits for burn wound healing, including infection prevention and moisture management, and discuss the potential risks of using the patient's preferred ointment, such as delayed healing or increased infection risk, before collaboratively deciding on the best course of action. Explanation. This scenario presents a professional challenge due to the inherent conflict between patient autonomy and the clinician's responsibility to provide evidence-based care, particularly when a patient's request may compromise optimal wound healing. The clinician must navigate this ethical tightrope, balancing respect for the patient's wishes with the imperative to adhere to established best practices in burn wound management, as outlined by ABLS guidelines. The correct approach prioritizes a thorough assessment and patient education before agreeing to a less-than-ideal dressing. This aligns with ABLS principles that emphasize individualized care and the importance of patient understanding. By explaining the rationale behind specific dressing choices and the potential consequences of deviating from them, the clinician upholds the ethical principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm. Furthermore, it respects patient autonomy by involving them in the decision-making process after providing them with accurate information. This approach fosters trust and adherence to the treatment plan, ultimately contributing to better outcomes. An incorrect approach would be to immediately accede to the patient's request without adequate assessment or education. This failure to explore the underlying reasons for the patient's preference and to explain the potential risks associated with a non-standard dressing constitutes a breach of professional responsibility. It could lead to suboptimal wound healing, increased risk of infection, or prolonged recovery, violating the principles of beneficence and non-maleficence. Another incorrect approach would be to dismiss the patient's concerns outright, demonstrating a lack of respect for their autonomy and potentially damaging the therapeutic relationship. This paternalistic stance fails to acknowledge the patient's right to be informed and involved in their care. The professional decision-making process in such situations should involve a systematic approach. First, actively listen to and understand the patient's concerns and preferences. Second, conduct a comprehensive assessment of the wound and the patient's overall condition. Third, educate the patient about the rationale behind recommended wound care practices, including the benefits of specific cleansing agents, debridement techniques, and dressing materials, as well as the potential risks of alternatives. Fourth, collaboratively develop a treatment plan that, whenever possible, incorporates the patient's preferences while adhering to evidence-based guidelines. Finally, document the discussion, the rationale for the chosen approach, and the patient's informed consent. Question 3. The investigation demonstrates that a rescuer, while attending to a patient with a significant thermal burn, experienced a strong personal aversion to the appearance of the damaged tissue, leading to a hesitation in initiating the standard cooling procedure. This hesitation resulted in a delay of approximately 2 minutes before cool water was applied. The rescuer then proceeded to cover the burn with a clean, dry cloth. Considering the established Advanced Burn Life Support ABLS guidelines for initial management, which of the following actions, if taken by the rescuer, would represent the most appropriate and ethically sound response to this situation? Option A. Cover the burn immediately with a sterile, non-adherent dressing to prevent infection, and then proceed with cooling. Option B. Focus on comforting the patient verbally and reassuring them about their appearance before commencing any physical interventions. Option C. Apply ice packs directly to the burn to rapidly reduce the temperature and minimize tissue damage. Option D. Immediately initiate cooling of the burn with cool, running water for at least 10-20 minutes and then cover the wound with a clean, dry dressing. The correct answer is D. Immediately initiate cooling of the burn with cool, running water for at least 10-20 minutes and then cover the wound with a clean, dry dressing. Explanation. This scenario presents an ethical dilemma in the initial management of a burn injury, specifically concerning the balance between immediate patient comfort and adherence to established ABLS protocols. The challenge lies in the rescuer's personal discomfort with the patient's appearance and the potential for this to influence critical, time-sensitive first aid decisions. The correct approach prioritizes the patient's immediate well-being and adherence to ABLS guidelines for initial burn management. This involves prompt cooling of the burn with cool, not cold, water, and covering the wound with a clean, dry dressing. This aligns with ABLS principles that emphasize minimizing further tissue damage by reducing heat transfer and preventing contamination. Ethically, this approach upholds the principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm. Regulatory frameworks for ABLS certification implicitly endorse these principles by outlining evidence-based best practices for emergency burn care. An incorrect approach that involves delaying cooling due to personal aversion or focusing on aesthetic concerns before essential first aid fails to meet the core objectives of ABLS. This could be considered a failure of professional duty, potentially leading to increased pain and deeper tissue injury for the patient. Ethically, it violates the principles of beneficence and non-maleficence. Regulatory failure would stem from not following the prescribed ABLS protocols, which are designed to optimize patient outcomes in emergency situations. Another incorrect approach might be to apply ice directly to the burn. While seemingly a more aggressive cooling method, ABLS guidelines specifically caution against this as it can cause further tissue damage, frostbite, and vasoconstriction, hindering blood flow to the injured area. This deviates from established best practices and could be seen as a failure to apply knowledge gained through ABLS certification, thus representing a regulatory and professional lapse. The professional decision-making process in such a situation requires the rescuer to compartmentalize personal feelings and focus solely on the patient's immediate needs and the established protocols. A structured approach involves 1. Rapidly assessing the burn injury according to ABLS criteria. 2. Immediately initiating the prescribed first aid steps, cooling and covering. 3. Prioritizing actions based on their impact on patient outcome, not personal comfort or aesthetics. 4. Recognizing that adherence to ABLS protocols is a professional obligation. Question 4. Upon reviewing a patient with extensive full-thickness burns to the anterior chest and abdomen following a structural collapse, what is the most critical initial assessment to guide immediate management, considering the potential for associated injuries? Option A. Immediately initiate large volume fluid resuscitation based on estimated total body surface area burned. Option B. Assess for signs of inhalation injury and ensure airway patency. Option C. Evaluate for associated fractures and internal bleeding. Option D. Prioritize pain management and wound coverage to prevent hypothermia. The correct answer is B. Assess for signs of inhalation injury and ensure airway patency. Explanation. Scenario analysis. This scenario is professionally challenging because accurately identifying the mechanism of burn injury is crucial for predicting the depth and extent of tissue damage, guiding immediate management, and anticipating potential complications. Misinterpreting the mechanism can lead to delayed or inappropriate treatment, impacting patient outcomes. The ABLS certification emphasizes a systematic approach to burn care, and understanding the mechanism is a foundational step. Correct approach analysis. The correct approach involves a thorough history and physical examination, specifically looking for clues related to the mechanism. For example, a history of being near an explosion suggests a potential for thermal and chemical burns, or even blast injuries. Observing soot around the nares or mouth, or hearing hoarseness, strongly indicates inhalation injury, a critical component of burn management that requires immediate airway assessment and potential intervention. This aligns with ABLS' principles of rapid assessment and identification of life-threatening conditions. Incorrect approach is analysis. One incorrect approach would be to solely focus on the visible skin damage without considering other potential injury mechanisms. This fails to account for the possibility of inhalation injury, which can be life-threatening and requires specific management protocols not directly evident from skin burns alone. Ethically, this represents a failure to provide comprehensive care. Another incorrect approach is to assume a single mechanism when multiple could be present, such as assuming a simple thermal burn when chemical exposure may have also occurred. Chemical burns can continue to cause damage until completely removed, and their management differs significantly from thermal burns. This oversight constitutes a failure to adhere to best practices in burn assessment as outlined by ABLS guidelines. A further incorrect approach is to delay assessment of airway patency and breathing, focusing only on fluid resuscitation based on estimated burn size. Inhalation injury can cause airway edema and obstruction, making airway management the absolute priority. Delaying this assessment, as per ABLS protocols, is a critical failure in patient safety and professional responsibility. Professional reasoning. Professionals should approach burn patients with a high index of suspicion for multiple injury mechanisms, especially in cases of significant burns or those involving explosions or confined spaces. A systematic approach, starting with a rapid primary survey, including airway, breathing, circulation, disability, and exposure, is paramount. The history should actively seek information about the circumstances of the burn. Physical examination should meticulously search for signs of inhalation injury, facial burns, soot, hoarseness, stridor, and chemical exposure. This comprehensive assessment informs the subsequent management plan, ensuring that all life-threatening aspects of the burn injury are addressed according to established ABLS guidelines. Question 5. The performance metrics show a tendency for new clinicians to classify all blistered burns as superficial partial thickness, potentially delaying appropriate interventions for deeper injuries. Which of the following assessment strategies best aligns with advanced burn life support ABLS principles for accurately determining burn depth in such scenarios? Option A. Prioritize visual inspection of the burn wound, noting color, presence, and size of blisters, capillary refill, and the presence or absence of eschar in conjunction with the patient's reported sensation. Option B. Immediately initiate full-thickness burn protocols for any burn exhibiting blistering to ensure comprehensive coverage. Option C. Classify any burn with visible blisters as superficial partial thickness, as this is the most common presentation of such injuries. Option D. Rely primarily on the patient's description of pain intensity, assuming that higher pain levels correlate directly with deeper burns. The correct answer is A. Prioritize visual inspection of the burn wound, noting color, presence and size of blisters, capillary refill, and the presence or absence of eschar, in conjunction with the patient's reported sensation. Explanation. The performance metrics show a consistent underestimation of burn depth by junior staff, leading to delayed or inappropriate treatment protocols. This scenario is professionally challenging because accurate burn depth assessment is critical for effective patient management, directly impacting outcomes and resource allocation. Misclassifying burn depth can lead to severe complications, including infection, increased scarring, prolonged healing, and unnecessary surgical interventions or, conversely, insufficient care for deep injuries. The ABLS certification emphasizes this foundational skill, requiring practitioners to demonstrate proficiency in differentiating between superficial, partial thickness, and full-thickness burns. The correct approach involves a systematic and thorough assessment of the burn wound, considering visual cues such as color, presence of blisters, capillary refill, and the patient's reported sensation. This aligns with ABLS guidelines which stress a hands-on, observational approach to determine the extent of dermal damage. Best professional practice dictates that a clinician must be able to accurately categorize the burn depth to initiate the appropriate resuscitation, wound care, and pain management strategies as outlined by ABLS protocols. This ensures patient safety and adherence to evidence-based standards of care. An incorrect approach would be to rely solely on the patient's subjective report of pain without objective visual assessment. Sensation is a factor. It can be unreliable, especially in partial thickness burns where nerve endings may be damaged or intact. This failure to conduct a comprehensive visual assessment violates ABLS principles of objective evaluation and can lead to misdiagnosis. Another incorrect approach is to assume all burns with blistering are superficial partial thickness, neglecting the possibility of deeper involvement or the need for further investigation. This oversimplification ignores the nuances of burn wound healing and potential for complications, deviating from the detailed diagnostic criteria taught in ABLS. Finally, a failure to document the assessed burn depth and the rationale for that assessment is a significant professional and ethical lapse, hindering continuity of care and peer review. Professionals should approach burn depth assessment by first recalling the ABLS mnemonic for burn assessment, which guides a structured evaluation. This involves observing the wound characteristics, considering the mechanism of injury, and assessing for signs of systemic involvement. If there is any doubt, it is always safer to err on the side of caution and consider the burn to be deeper, initiating more conservative management and seeking senior or specialist consultation. Continuous self-assessment and seeking feedback on performance metrics are crucial for maintaining and improving this vital skill. Question 6. Examination of the data shows a patient presenting with extensive full-thickness burns covering 40% of their total body surface area. The initial assessment reveals a rapid heart rate, decreased blood pressure, and diminished urine output. Which of the following management strategies best addresses the immediate systemic effects of this burn injury according to Advanced Burn Life Support ABLS principles? Option A. Initiate aggressive intravenous fluid resuscitation with isotonic crystalloids, closely monitoring cardiovascular status and urine output, while preparing for airway management if indicated by respiratory compromise. Option B. Provide supplemental oxygen and monitor vital signs, awaiting specialist consultation before initiating any significant interventions. Option C. Focus on immediate wound debridement and application of topical antimicrobial agents to prevent infection. Option D. Administer broad-spectrum antibiotics and pain medication, deferring significant fluid resuscitation until the patient is stabilized in the operating room. The correct answer is A. Initiate aggressive intravenous fluid resuscitation with isotonic crystalloids, closely monitoring cardiovascular status and urine output, while preparing for airway management if indicated by respiratory compromise. Explanation: this scenario is professionally challenging due to the rapid and complex systemic effects of severe burns, requiring immediate and accurate assessment to guide appropriate resuscitation and management. The ABLS certification emphasizes a systematic approach to burn care, and understanding the physiological cascade is paramount. The correct approach represents best professional practice because it aligns with the core principles of Advanced Burn Life Support, which prioritize the immediate recognition and management of life-threatening systemic consequences of burns. This includes understanding how massive fluid shifts, inflammatory mediators, and direct tissue damage impact cardiovascular stability, respiratory function, renal perfusion, and overall metabolic state. Adhering to established ABLS guidelines ensures a standardized, evidence-based approach to patient care, minimizing preventable complications and improving outcomes. This is ethically mandated by the professional responsibility to provide competent and timely care. An incorrect approach that focuses solely on local wound management without addressing systemic effects fails to recognize the immediate life threats posed by a large burn. This is a regulatory and ethical failure as it deviates from established burn care protocols, potentially leading to hypovolemic shock, respiratory compromise, and organ dysfunction, which are preventable with prompt systemic intervention. Another incorrect approach that prioritizes aggressive fluid resuscitation without considering the specific burn size and depth, or the patient's underlying conditions, can lead to fluid overload and its associated complications, such as pulmonary edema. This is a failure to apply the principles of appropriate resuscitation as taught in ABLS, which emphasizes individualized fluid management based on burn severity and patient response. A third incorrect approach that neglects to monitor or address the metabolic derangements, such as hyperglycemia or hypothermia, overlooks critical aspects of burn pathophysiology. This represents a failure to provide comprehensive care as expected within the scope of advanced burn management, potentially exacerbating patient morbidity. The professional decision-making process for similar situations involves a rapid primary survey, ABCs, followed by a secondary survey that specifically assesses the systemic impact of the burn. This includes evaluating hemodynamic status, respiratory effort, urine output, and metabolic indicators. Continuous reassessment and adjustment of interventions based on patient response are crucial, guided by the principles of ABLS and a thorough understanding of burn physiology. Question 7. Performance analysis shows that in initial burn patient encounters, a common challenge is the rapid and accurate assessment of severity and immediate life threats. Which of the following initial assessment strategies best aligns with advanced burn life support (ABLS) principles for a patient presenting with smoke inhalation and significant burns? Option A. Focus solely on the percentage of TBSA burned and defer any assessment of breathing or circulation until the patient is stabilized from a pain perspective. Option B. Immediately begin a detailed history of the burn incident and the patient's medical background before assessing vital signs or airway. Option C. Prioritize the estimation of total body surface area, TBSA, burned and initiate pain management before evaluating for signs of airway compromise. Option D. Conduct a rapid primary survey, airway, breathing, circulation, followed by a secondary survey to identify inhalation injury, burn depth, extent, and other trauma, and then initiate appropriate fluid resuscitation. Correct answer is B. Immediately begin a detailed history of the burn incident and the patient's medical background before assessing vital signs or airway. Explanation. Scenario analysis. This scenario is professionally challenging due to the rapid and dynamic nature of burn emergencies. Effective initial assessment and triage are critical for patient survival and optimal outcomes. The challenge lies in quickly and accurately identifying the severity of burns, associated injuries, and the patient's overall physiological status under pressure, often with limited resources. Misjudgment can lead to delayed or inappropriate treatment, exacerbating patient harm. Correct approach analysis. The correct approach prioritizes a systematic and evidence-based assessment that aligns with advanced burn life support (ABLS) principles. This involves a rapid primary survey, ABC's airway, breathing, circulation, to identify and manage immediate life threats, followed by a secondary survey focused on burn-specific details like depth, extent, and location, as well as identifying potential inhalation injury and other concomitant trauma. This systematic approach ensures that the most critical interventions are performed first, directly reflecting ABLS guidelines which emphasize immediate life support and accurate assessment for appropriate disposition and treatment. Incorrect approach is analysis, an approach that solely focuses on the percentage of total body surface area, TBSA, burned without a thorough assessment of airway patency or signs of inhalation injury is a significant regulatory and ethical failure. ABLS mandates a comprehensive evaluation, not just a numerical calculation. Ignoring potential airway compromise can lead to rapid deterioration and death, violating the ethical duty to provide competent care and the regulatory requirement to adhere to established life support protocols. Another incorrect approach is to delay fluid resuscitation until after a detailed history of the burn incident is obtained. While history is important, ABLS emphasizes the immediate need for fluid resuscitation in patients with significant burns to prevent hypovolemic shock. Delaying this critical intervention constitutes a failure to adhere to established best practices and can result in severe patient harm, a breach of professional duty. An approach that prioritizes pain management over the assessment of vital signs and airway status is also ethically and regulatorily flawed. While pain management is crucial, it must not supersede the immediate life-saving interventions required in burn patients. Failure to address life-threatening issues first is a direct contravention of ABLS principles and professional responsibility. Professional reasoning. Professionals should employ a structured decision-making process that begins with a rapid primary survey to ensure airway, breathing, and circulation are secured. This is immediately followed by a focused secondary survey to gather essential burn-specific information, including TBSA estimation, depth, location, and signs of inhalation injury. Concurrent assessment of vital signs and the patient's overall condition is paramount. This systematic, ABLS-aligned approach ensures that critical interventions are initiated promptly and that the patient is triaged appropriately for definitive care, minimizing the risk of preventable complications and mortality. Question 8. Governance review demonstrates a critical incident involving a burn patient where initial fluid resuscitation was based on a generalized percentage of total body surface area burned, without a detailed assessment of burn depth or ongoing physiological monitoring. Which of the following approaches best reflects the principles of advanced burn life support ABLS in determining fluid resuscitation needs for a burn patient? Option A. Utilize a standardized fluid resuscitation formula for all burn patients, irrespective of specific burn characteristics or the presence of inhalation injury. Option B. Initiate fluid resuscitation based on a calculated volume derived from the estimated burn size and depth, with continuous reassessment of the patient's hemodynamic status and urine output to guide adjustments. Option C. Delay fluid resuscitation until the patient is stabilized for definitive surgical debridement and grafting. Option D. Administer a fixed volume of intravenous fluid for any burn exceeding 20% total body surface area, regardless of burn depth or patient response. The correct answer is B. Initiate fluid resuscitation based on a calculated volume derived from the estimated burn size and depth, with continuous reassessment of the patient's hemodynamic status and urine output to guide adjustments. Explanation: this scenario is professionally challenging due to the critical need for accurate and timely fluid resuscitation in burn patients, directly impacting patient outcomes and adherence to established burn care protocols. The complexity arises from the dynamic nature of burn injury and the potential for rapid fluid shifts, requiring a nuanced understanding of burn size and depth assessment to guide resuscitation efforts effectively. The correct approach represents best professional practice because it aligns with the fundamental principles of advanced burn life support ABLS, as outlined in its certification guidelines. These guidelines emphasize a systematic and evidence-based approach to fluid resuscitation, prioritizing patient safety and optimal recovery. Specifically, the correct approach reflects the understanding that fluid needs are not static and require ongoing reassessment, a core tenet of effective burn management. This ensures that resuscitation is tailored to the individual patient's physiological response, preventing both undersuscitation, leading to hypoperfusion and organ damage, and oversuscitation, contributing to edema, compartment syndrome, and respiratory compromise. Adherence to these established protocols is ethically mandated to provide the highest standard of care. An incorrect approach that relies solely on a fixed volume of fluid for any burn of a certain percentage, without considering the depth or ongoing patient assessment, represents a significant regulatory and ethical failure. This approach disregards the variability in burn depth and its impact on fluid requirements, potentially leading to inadequate resuscitation for deep burns or excessive fluid for superficial ones. Such a deviation from ABLS guidelines constitutes a failure to adhere to established best practices and could be considered a breach of professional duty of care. Another incorrect approach that involves delaying fluid resuscitation until definitive surgical intervention is also professionally unacceptable. Burn patients require immediate fluid resuscitation to maintain hemodynamic stability. Delaying this critical intervention, even in anticipation of surgery, can lead to irreversible organ damage and increased mortality. This failure to initiate timely resuscitation directly contravenes the life-saving principles of ABLS and represents a critical ethical lapse. Finally, an approach that uses a generic fluid resuscitation formula without accounting for specific burn characteristics, such as the presence of inhalation injury or pre-existing comorbidities, is also flawed. While formulas provide a starting point, ABLS emphasizes the importance of clinical judgment and patient-specific factors in guiding resuscitation. Ignoring these variables can lead to suboptimal fluid management and adverse patient outcomes, failing to meet the standard of individualized care expected in burn management. The professional decision-making process for similar situations should involve a thorough initial assessment of burn size and depth, followed by the initiation of fluid resuscitation according to ABLS guidelines. Crucially, this process must include continuous monitoring of the patient's physiological parameters, e.g., urine output, heart rate, blood pressure, and frequent reassessment of fluid needs. This iterative approach allows for adjustments to the resuscitation rate and volume, ensuring that the patient remains hemodynamically stable and that complications are minimized. Professionals must remain vigilant, applying critical thinking to adapt resuscitation strategies based on the patient's evolving condition and in strict accordance with established burn care protocols. Question 9. Analysis of how the application of the rule of nines for burn surface area estimation is impacted by patient demographics and the subsequent clinical implications for initial management. Option A. The rule of nines is primarily a historical tool with limited practical value in modern burn care, and other assessment methods are preferred. Option B. Age-specific modifications to the rule of nines are crucial for accurate burn surface area estimation, particularly in pediatric patients, to ensure appropriate fluid resuscitation and treatment planning. Option C. The standard adult rule of nines is universally applicable across all age groups, and any deviation is unnecessary. Option D. Visual estimation alone is sufficient for determining burn surface area, rendering standardized formulas like the rule of nines redundant. Correct answer is C. The standard adult rule of nines is universally applicable across all age groups, and any deviation is unnecessary. Explanation. The scenario presents a common challenge in burn management, accurately assessing the extent of a burn injury to guide treatment decisions. The rule of nines is a foundational tool for this estimation, but its application requires understanding its limitations and appropriate use in different patient populations. The professional challenge lies in moving beyond a rote application of the formula to a nuanced understanding of how patient factors can influence the accuracy of the estimation and, consequently, the subsequent clinical management. The correct approach emphasizes the importance of considering patient age when applying the rule of nines. This is because the proportions of body surface area represented by each segment of the rule of nines change significantly from infancy to adulthood. For example, the head represents a larger percentage of body surface area in infants and young children than in adults, while the lower extremities represent a smaller percentage. Failure to adjust for age can lead to significant under- or overestimation of burn size, impacting fluid resuscitation calculations, nutritional support, and surgical planning. This aligns with best professional practice by ensuring that the estimation tool is used in a manner that is clinically relevant and accurate for the individual patient, thereby optimizing care and minimizing potential harm. An incorrect approach would be to rigidly apply the standard adult rule of nines to a pediatric patient without any modification. This represents a failure to adhere to established clinical guidelines that acknowledge age-related anatomical differences. Ethically, this could be considered a deviation from the standard of care, potentially leading to inadequate resuscitation and adverse patient outcomes. Another incorrect approach would be to rely solely on visual estimation without using a standardized method like the rule of nines, even for a small burn. While visual estimation might seem quicker, it is highly subjective and prone to significant error, lacking the systematic approach required for reliable assessment. This undermines the principle of evidence-based practice and can lead to inconsistent and potentially harmful treatment decisions. Professionals should approach burn surface area estimation by first identifying the patient's age. For adult patients, the standard rule of nines is generally applicable. For pediatric patients, age-adjusted charts or modified rule of nines formulas should be consulted and utilized. Visual estimation should be used as a supplementary tool, not a primary method, and always validated against a standardized approach. The decision-making process should prioritize accuracy and patient safety, ensuring that the chosen method provides the most reliable estimate for guiding subsequent management. Question 10. Strategic planning requires a thorough understanding of potential hazards to effectively manage patient care. In a pre-hospital setting, a patient presents with a burn injury. The initial assessment must prioritize identifying the cause of the burn to guide immediate interventions and subsequent management. Which of the following approaches best reflects the critical initial step in classifying the burn injury according to Advanced Burn Life Support ABLS principles? Option A. Determining the depth and extent of the burn based on visual inspection alone. Option B. Focusing treatment on pain management and wound dressing without identifying the burn type. Option C. Immediately initiating fluid resuscitation without considering the burn's origin. Option D. Ascertaining the mechanism of injury through patient history and scene assessment. The correct answer is A. Determining the depth and extent of the burn based on visual inspection alone. Explanation. This scenario is professionally challenging due to the immediate need to accurately classify a burn injury to guide appropriate initial management, which is critical for patient outcomes. The complexity arises from the potential for multiple burn etiologies and the need to differentiate them based on initial presentation and patient history, as different burn types require distinct interventions. Careful judgment is required to avoid misclassification, which could lead to delayed or inappropriate treatment, exacerbating tissue damage and increasing morbidity. The correct approach represents best professional practice because it prioritizes a systematic assessment that aligns with the Advanced Burn Life Support (ABLS) principles. This involves a thorough history and physical examination to identify the mechanism of injury, which is fundamental to classifying the burn as thermal, chemical, electrical, or radiation. Understanding the specific etiology dictates immediate interventions, such as decontamination for chemical burns, assessment for systemic effects in electrical burns, or protection from further radiation exposure. This aligns with ABLS guidelines emphasizing rapid assessment and management based on the mechanism of injury to stabilize the patient and prevent further harm. An incorrect approach that focuses solely on the visual appearance of the burn without considering the mechanism of injury is professionally unacceptable. This failure stems from a lack of adherence to ABLS principles that stress the importance of etiology. For instance, mistaking an electrical burn for a superficial thermal burn could lead to overlooking potentially life-threatening internal injuries or arrhythmias. Similarly, neglecting to inquire about chemical exposure could result in continued tissue damage if decontamination is not initiated promptly. These omissions represent a failure to provide evidence-based care and a deviation from the standard of care expected in burn management. Another incorrect approach that prioritizes treating only the most superficial aspects of the burn without a comprehensive assessment of the mechanism is also professionally unsound. This overlooks the potential for deeper or systemic injuries associated with certain burn types. For example, a seemingly small electrical entry wound might mask significant internal damage, and a failure to investigate this mechanism thoroughly would be a critical oversight. This approach demonstrates a lack of understanding of the multifaceted nature of burn injuries and the ABLS requirement for a holistic, mechanism-driven evaluation. The professional decision-making process for similar situations should involve a structured approach. 1. Immediate scene safety and patient assessment. Ensure the environment is safe and perform a rapid primary survey ABCs. 2. Mechanism of injury identification. Actively seek information about how the burn occurred. This is paramount for classification. 3. Burn classification. Based on the mechanism, categorize the burn: thermal, chemical, electrical. Radiation. 4. Targeted assessment and management. Tailor interventions to the specific burn type following ABLS protocols. 5. Reassessment and ongoing monitoring. Continuously evaluate the patient's response to treatment and adjust management as needed. Question 11. The monitoring system demonstrates a decreasing capillary refill time in the digits of the patient's left arm, which has a full-thickness circumferential burn of the forearm. The patient reports increasing numbness and a sensation of tightness in the affected limb. What is the most appropriate immediate surgical intervention? Option A. Proceed directly to a fasciotomy of the forearm compartments. Option B. Initiate aggressive intravenous fluid resuscitation and reassess in 1 hour. Option C. Delay intervention until distal pulses are no longer palpable. Option D. Perform an escherotomy of the circumferential burn eschar on the forearm. The correct answer is D. Perform an escherotomy of the circumferential burn eschar on the forearm. Explanation. This scenario presents a common but critical challenge in burn management, recognizing and intervening in circumferential burns that compromise circulation. The professional challenge lies in the rapid assessment of evolving signs of compromise and the timely, decisive application of surgical interventions to prevent irreversible tissue damage and limb loss. The urgency is amplified by the potential for rapid deterioration. The correct approach, performing an escherotomy, represents best professional practice because it directly addresses the constricting eschar that is impeding venous and arterial outflow. This procedure is a cornerstone of emergent burn care, guided by established ABLS principles and clinical guidelines that prioritize restoring perfusion. The ethical imperative is to act decisively to preserve limb viability and patient well-being, adhering to the principle of beneficence. An incorrect approach of delaying intervention until more definitive signs of ischemia appear, such as absent pulses or frank necrosis, is professionally unacceptable. This delay constitutes a failure to adhere to the proactive management principles outlined in ABLS, potentially leading to irreversible damage and the need for more radical surgical procedures, such as amputation. Ethically, this delay violates the principle of non-maleficence by allowing preventable harm to occur. Another incorrect approach, opting for immediate fasciotomy without a clear indication of intracompartmental pressure elevation or compartment syndrome, is also professionally unsound. While fasciotomy is a related surgical intervention, it is indicated for compartment syndrome, not directly for the constricting eschar itself. Performing an unnecessary fasciotomy carries risks of infection, bleeding, and delayed wound healing without addressing the primary problem of the circumferential burn. This represents a failure to apply the correct diagnostic and therapeutic pathway as taught in ABLS. Finally, an incorrect approach of solely relying on fluid resuscitation to manage signs of circulatory compromise in a circumferential burn is insufficient. While adequate fluid resuscitation is vital for burn shock management, it does not relieve the mechanical compression caused by the inelastic eschar. This approach fails to recognize the specific surgical requirement of the burn pathophysiology and risks allowing progressive ischemia. The professional decision-making process for similar situations involves a systematic assessment of the burn wound, including its depth, extent, and location, with a particular focus on circumferential burns. Continuous monitoring of distal perfusion, capillary refill, and sensory/motor function is paramount. When signs of compromise emerge, even subtly, the threshold for considering escherotomy should be low, guided by ABLS protocols and clinical experience. Question 12. Research into optimal pain management for severe burn patients undergoing wound debridement suggests that a comprehensive approach is essential. Considering the principles of advanced burn life support ABLS, which of the following strategies best reflects current best practice for managing acute procedural pain in these individuals? Option A. Relying solely on topical anesthetic creams applied to the burn wound hours before the procedure to numb the area. Option B. Providing oral acetaminophen and ibuprofen as the primary analgesics, with no additional interventions considered unless the patient explicitly requests more. Option C. Administering a continuous infusion of a long-acting sedative agent without concurrent analgesia, assuming the patient will be too sedated to perceive pain. Option D. Administering a combination of intravenous opioids and a short-acting benzodiazepine prior to the procedure, coupled with non-pharmacological distraction techniques during debridement. The correct answer is D. Administering a combination of intravenous opioids and a short-acting benzodiazepine prior to the procedure, coupled with non-pharmacological distraction techniques during debridement. Explanation. The scenario of managing pain in burn patients is professionally challenging due to the extreme severity of the pain, the patient's compromised physiological state, and the need for rapid, effective interventions while minimizing risks. Burn patients often experience severe, persistent, and multifaceted pain, including procedural pain, wound care dressing changes, background pain at rest, and breakthrough pain. The ABLS certification emphasizes a systematic approach to burn care, and pain management is a critical component that directly impacts patient outcomes, including wound healing, psychological well-being, and overall recovery. Careful judgment is required to balance the benefits of analgesia with potential adverse effects, especially in a critically ill population. The correct approach represents best professional practice by prioritizing multimodal pain management strategies that are evidence-based and tailored to the individual patient's needs and the specific phase of burn care. This aligns with the ethical imperative to relieve suffering and the regulatory expectation to provide a standard of care that is safe and effective. Utilizing a combination of pharmacological agents, e.g., opioids, non-opioids, adjuvant medications, and non-pharmacological interventions, e.g., distraction, relaxation techniques, therapeutic positioning, addresses the complex nature of burn pain. This approach is supported by ABLS principles that advocate for comprehensive patient assessment and management. An incorrect approach that relies solely on a single class of analgesics, such as only administering oral non-opioids for severe burn pain, fails to adequately address the intensity of the pain and can lead to undertreatment, patient suffering, and potential complications. This represents a failure to meet the standard of care and an ethical lapse in relieving suffering. Another incorrect approach that involves administering high doses of sedatives without adequate analgesia for pain management can mask pain, leading to potential physiological distress and delayed recognition of complications, which is a regulatory and ethical failure to provide appropriate care. Furthermore, neglecting to reassess pain levels and the effectiveness of interventions after administration is a critical oversight, as it prevents timely adjustments to the treatment plan, leading to prolonged suffering and potentially suboptimal outcomes, violating the principle of ongoing patient assessment and care. Professional decision-making in similar situations requires a systematic process. 1. Thoroughly assess the patient's pain, including its intensity, location, quality, and impact on function, using validated pain scales. 2. Identify the type of pain, nociceptive, neuropathic, procedural background. 3. Develop a multimodal pain management plan that incorporates pharmacological and non-pharmacological interventions, considering the patient's age, comorbidities, and current physiological status. 4. Administer analgesics and other interventions promptly and titrate to effect, monitoring for efficacy and adverse events. 5. Continuously reassess the patient's pain and the effectiveness of the treatment plan, making adjustments as needed. 6. Document all assessments, interventions, and outcomes meticulously. This iterative process ensures that pain management is dynamic and responsive to the patient's evolving needs, adhering to best practices and regulatory requirements. Question 13. Operational review demonstrates that, while staff in the burn unit consistently practice hand hygiene, there are observed inconsistencies in the frequency and thoroughness of environmental disinfection of patient care equipment and surfaces, and the selection and use of personal protective equipment, PPE, for specific procedures. Which of the following approaches best aligns with comprehensive infection prevention and control measures for a burn unit? Option A. Develop a comprehensive infection control manual that outlines all procedures and distribute it to all staff for their review. Option B. Reinforce hand hygiene protocols through mandatory retraining for all staff and increase the frequency of hand hygiene audits. Option C. Implement a mandatory daily checklist for all staff to document environmental disinfection and PPE usage, coupled with regular unannounced audits and immediate feedback sessions for any deviations. Option D. Focus on enhancing patient isolation protocols, ensuring all patients are placed in appropriate isolation rooms with strict visitor restrictions. Correct answer is C. Implement a mandatory daily checklist for all staff to document environmental disinfection and PPE usage, coupled with regular unannounced audits and immediate feedback sessions for any deviations. Explanation. Scenario analysis. This scenario presents a common challenge in healthcare settings, ensuring consistent adherence to infection prevention protocols in a high-risk environment like a burn unit. The professional challenge lies in balancing the immediate needs of critically ill patients with the long-term imperative of preventing healthcare-associated infections, which can significantly worsen patient outcomes and increase resource utilization. The critical judgment required involves evaluating the effectiveness and practicality of different infection control strategies in a dynamic clinical setting. Correct approach analysis. The correct approach emphasizes a multifaceted strategy that aligns with established best practices in infection prevention and control, as would be expected within the ABLS framework. This includes rigorous hand hygiene, appropriate use of personal protective equipment, PPE, meticulous environmental cleaning and disinfection, and effective sterilization of equipment. The rationale behind this approach is that it addresses multiple transmission routes of pathogens. Hand hygiene is the single most effective measure to prevent the spread of microorganisms. Proper PPE acts as a barrier between the healthcare worker and the patient, or between the patient and the environment. Environmental cleaning and disinfection reduce the bioburden on surfaces and equipment. Sterilization ensures that reusable medical devices are free from all microbial life. These measures are foundational to preventing infections in vulnerable populations like burn patients, whose compromised skin barrier makes them highly susceptible to infection. Adherence to these principles is not only a matter of clinical best practice, but also a regulatory expectation for patient safety. Incorrect approaches analysis. Focusing solely on hand hygiene without addressing other critical elements like environmental cleaning or PPE is insufficient. While hand hygiene is paramount, it is one component of a comprehensive infection control program. Neglecting environmental disinfection can leave reservoirs of pathogens that can be transmitted through contact or aerosolization, even with diligent hand hygiene. Similarly, relying solely on PPE without ensuring proper donning, doffing, and disposal can lead to cross-contamination. An approach that prioritizes only patient isolation without robust environmental controls and staff education fails to address the broader spectrum of infection transmission pathways within the unit. Isolation is a crucial tool, but it is most effective when integrated with other preventive measures. Over-reliance on isolation alone can be resource-intensive and may not fully mitigate risks if other control measures are weak. Furthermore, a reactive approach, such as only implementing enhanced cleaning after an infection is identified, is a failure of proactive infection prevention and control, which is a cornerstone of regulatory compliance and ethical patient care. Proactive measures aim to prevent infections before they occur. Professional reasoning. Professionals should approach infection prevention and control with a proactive, layered strategy. This involves continuous assessment of risks, implementation of evidence-based interventions, and ongoing education and monitoring of staff compliance. The decision-making process should be guided by a thorough understanding of the principles of epidemiology and microbiology as applied to healthcare settings, as well as the specific vulnerabilities of burn patients. A systematic approach that integrates hand hygiene, PPE use, environmental management, and appropriate patient placement, all supported by regular audits and feedback, is essential for maintaining a safe patient environment and meeting professional and regulatory standards. Question 14. Stakeholder feedback indicates a need to reinforce the foundational principles of fluid resuscitation in burn patients within the ABLS certification framework. Considering a 45-year-old male weighing 70 kg with a full-thickness burn covering 30% of his total body surface area, which of the following initial fluid resuscitation strategies best adheres to the ABLS principles for immediate management? Option A. Initiate resuscitation with a colloid solution such as albumin, given the large surface area burn. Option B. Administer lactated Ringer solution at a rate calculated to deliver half of the estimated 24-hour requirement in the first 8 hours post-burn. Option C. Delay fluid administration until the patient's airway is definitively secured and the extent of inhalation injury is fully assessed. Option D. Begin immediate administration of 5% dextrose in water, D5W, at a rapid infusion rate to address dehydration. Correct answer is B. Administer lactated Ringer solution at a rate calculated to deliver half of the estimated 24-hour requirement in the first 8 hours post-burn. Explanation. This scenario is professionally challenging due to the critical and time-sensitive nature of fluid resuscitation in severe burn patients. The rapid administration of appropriate fluids is paramount to prevent hypovolemic shock, organ damage, and to optimize patient outcomes. Misjudging the initial fluid needs or the type of fluid can have immediate and severe consequences. Careful judgment is required to balance adequate resuscitation with the risk of fluid overload, especially in patients with pre-existing conditions or those who may develop compartment syndrome. The correct approach represents best professional practice because it aligns with established advanced burn life support ABLS principles and guidelines, which are the regulatory framework for this certification. These guidelines emphasize the importance of calculating initial fluid requirements based on the patient's total body surface area, TBSA, burned and body weight, and initiating resuscitation with an isotonic crystalloid solution, typically lactated Ringers. This approach is evidence-based, aiming to restore intravascular volume effectively and safely. The ABLS framework prioritizes prompt and accurate fluid delivery to maintain hemodynamic stability and organ perfusion, thereby preventing secondary complications. An incorrect approach involving delayed initiation of fluid resuscitation represents a significant regulatory and ethical failure. The ABLS guidelines mandate immediate intervention for patients meeting specific burn severity criteria. Delaying resuscitation directly contravenes the core principle of timely patient care and can lead to irreversible organ damage, a clear violation of the duty of care owed to the patient. Another incorrect approach, such as using hypotonic fluids or colloids as the initial resuscitation fluid, is also a failure. Hypotonic fluids can exacerbate edema and are not recommended for burn resuscitation as they do not effectively expand intravascular volume. While colloids may have a role later in resuscitation, their initial use is generally discouraged by ABLS guidelines due to potential for adverse effects and lack of proven superiority over crystalloids in the early phase. This deviates from the established, evidence-based protocols that form the regulatory basis for ABLS certification. The professional reasoning process for similar situations should involve a systematic assessment of the burn injury, including TBSA and depth, patient's age, weight, and any comorbidities. This assessment should trigger the immediate application of ABLS fluid resuscitation formulas. Continuous monitoring of the patient's response to resuscitation, including urine output, heart rate, blood pressure, and mental status, is crucial for guiding ongoing fluid management. Professionals must remain vigilant for signs of inadequate or excessive resuscitation and be prepared to adjust the fluid rate accordingly, always referencing and adhering to the ABLS guidelines as the primary regulatory and clinical directive. Question 15. Which approach would be most appropriate for the initial assessment of a burn injury in a patient presenting to the emergency department, focusing on determining the severity and guiding immediate management according to advanced burn life support ABLS principles? Option A. Deferring a detailed burn assessment until after initial hemodynamic stabilization, assuming the primary focus is on airway and circulation. Option B. Focusing solely on calculating the percentage of total body surface area, TBSA, burned, without a detailed assessment of the burn depth. Option C. Relying primarily on the patient's self-reported pain level to gauge the severity of the burn and guide treatment decisions. Option D. A systematic visual and tactile examination to determine the burn depth, superficial, partial thickness, or full thickness, considering the presence of blisters, blanching, and capillary refill, alongside an estimation of the total body surface area, TBSA, affected. The correct answer is D. A systematic visual and tactile examination to determine the burn depth, superficial, partial thickness, or full thickness, considering the presence of blisters, blanching, and capillary refill, alongside an estimation of the total body surface area, TBSA, affected. Explanation. This scenario presents a professionally challenging situation due to the rapid and potentially misleading initial presentation of a burn injury. The challenge lies in accurately assessing the depth and extent of the burn, which directly dictates the urgency and type of intervention required according to advanced burn life support ABLS principles. Misjudging the depth can lead to delayed or inappropriate treatment, impacting patient outcomes. The need for swift, yet precise, assessment underscores the importance of adhering to established ABLS guidelines. The correct approach represents best professional practice because it prioritizes a systematic and evidence-based assessment of burn depth. This involves visual inspection and palpation to differentiate between superficial, partial thickness, and full thickness burns, considering factors like blanching, capillary refill, and the presence of blisters. This aligns with ABLS guidelines, which emphasize accurate depth assessment for appropriate fluid resuscitation, wound management, and potential referral decisions. Ethical practice demands that patient care be guided by validated protocols to ensure the best possible outcome, minimizing harm and maximizing benefit. An incorrect approach that relies solely on the patient's subjective report of pain is professionally unacceptable. While pain is a symptom, it is not a reliable indicator of burn depth. Superficial burns are often the most painful, while deep full-thickness burns may cause little to no pain due to nerve damage. This failure to conduct a thorough, objective assessment violates ABLS principles and could lead to undertreatment of a severe injury. Another incorrect approach that focuses only on the percentage of total body surface area, TBSA, without considering depth is also professionally flawed. While TBSA is crucial for fluid calculations, it is meaningless without an accurate depth assessment. A large superficial burn requires different management than a smaller but deep partial thickness or full thickness burn. This oversight neglects a fundamental component of burn assessment mandated by ABLS, potentially leading to inadequate care. A third incorrect approach that delays assessment until after initial stabilization without considering the burn's characteristics is also problematic. While ABCs, airway, breathing, circulation, are paramount in any emergency, a burn assessment should be integrated into the initial evaluation, especially for significant burns, to guide immediate management decisions regarding fluid resuscitation and pain control. Prolonged delay without considering burn depth can compromise the effectiveness of early interventions. The professional decision-making process for similar situations should involve a structured approach. First, ensure patient stability, ABCs. Second, perform a rapid, systematic assessment of the burn injury, focusing on depth, extent, TBSA, and location. Third, initiate appropriate interventions based on ABLS guidelines, including fluid resuscitation, pain management, and wound care. And finally, document findings and treatment meticulously, with consideration for specialist consultation or transfer if indicated. Question 16. The review process indicates a need to assess the understanding of the systemic consequences of a large thermal burn injury. A patient presents with extensive full-thickness burns covering 40% of their total body surface area. Within hours of the injury, the patient develops tachycardia, tachypnea, and a mild decrease in urine output. Which of the following best describes the underlying pathophysiological mechanism contributing to these systemic signs? Option A. The direct thermal damage to the skin causes immediate and irreversible destruction of all underlying tissues, resulting in profound local edema that restricts systemic circulation. Option B. The development of a burn wound infection is the most likely cause of the systemic signs, initiating a septic cascade that overwhelms the body's compensatory mechanisms. Option C. The patient's primary issue is hypovolemia due to evaporative water loss from the burn surface, leading to compensatory tachycardia and tachypnea as the body attempts to maintain oxygen delivery. Option D. The release of massive amounts of inflammatory mediators from the burn wound triggers a systemic inflammatory response, leading to increased capillary permeability, fluid shifts, and subsequent organ hypoperfusion. The correct answer is D. The release of massive amounts of inflammatory mediators from the burn wound triggers a systemic inflammatory response, leading to increased capillary permeability, fluid shifts, and subsequent organ hypoperfusion. Explanation. The review process indicates a need to evaluate the understanding of the pathophysiology of burns, specifically focusing on the systemic inflammatory response syndrome, SIRS, and its impact on organ systems. This scenario is professionally challenging because accurately assessing and managing the systemic effects of a burn injury requires a nuanced understanding of complex physiological processes that evolve over time. Misinterpreting these responses can lead to delayed or inappropriate interventions, significantly impacting patient outcomes. The correct approach represents best professional practice by accurately identifying the cascade of events initiated by burn injury, including the release of inflammatory mediators and the subsequent systemic effects. This aligns with the Advanced Burn Life Support (ABLS) principles, which emphasize a comprehensive understanding of burn pathophysiology to guide resuscitation and management. Recognizing the development of SIRS and its potential to progress to organ dysfunction is critical for timely and effective treatment, adhering to evidence-based guidelines for burn care. An incorrect approach that focuses solely on the local burn wound without considering systemic effects fails to acknowledge the profound physiological derangements that occur. This oversight represents a failure to adhere to ABLS principles, which mandate a holistic patient assessment. Another incorrect approach that attributes all systemic symptoms solely to hypovolemia without considering the inflammatory component neglects the complex interplay of factors contributing to organ dysfunction, potentially leading to over-resuscitation or misdirected treatment. A third incorrect approach that prematurely assumes sepsis without a clear microbiological diagnosis or definitive signs of infection, while a concern, can lead to unnecessary antibiotic use and delay in addressing the primary burn-related pathophysiology. These incorrect approaches demonstrate a lack of comprehensive understanding of burn pathophysiology and a deviation from best practice in patient management. Professional decision-making in similar situations requires a systematic approach. First, thoroughly assess the burn injury and the patient's hemodynamic status. Second, continuously monitor for signs of systemic inflammation and organ dysfunction. Third, integrate this information with the known pathophysiology of burns to formulate a differential diagnosis. And finally, implement interventions guided by evidence-based protocols, such as those outlined by ABLS, while remaining vigilant for evolving patient conditions. Question 17. The analysis reveals a patient presenting with circumferential partial thickness burns to the entire left arm and anterior chest following an electrical appliance malfunction. The patient is conscious but reports significant pain and difficulty breathing. Which of the following physical examination findings and subsequent actions best aligns with Advanced Burn Life Support ABLS principles for initial management? Option A. Relying on the patient's verbal report of pain to determine burn depth and initiating treatment based on that alone. Option B. Performing a detailed head-to-toe examination, documenting the estimated total body surface area, TBSA, burned, assessing burn depth, partial thickness, and noting the circumferential nature of the arm burn and any signs of respiratory distress. Option C. Documenting the burns as superficial based on initial visual inspection and administering oral analgesics. Option D. Focusing solely on the chest burn and initiating immediate fluid resuscitation without a full body assessment. The correct answer is C. Documenting the burns as superficial based on initial visual inspection and administering oral analgesics. Explanation. The analysis reveals a scenario where a patient presents with extensive burns following a household accident. The challenge lies in accurately assessing the extent and depth of these burns, as well as identifying any associated injuries that may not be immediately apparent. This requires a systematic and thorough physical examination, adhering to established ABLS protocols, to ensure appropriate initial management and prevent complications. The correct approach involves a comprehensive head-to-toe assessment, meticulously documenting the percentage of total body surface area, TBSA, burned and classifying the depth of each burn, superficial, partial thickness, full thickness. This systematic approach is crucial for guiding fluid resuscitation, pain management, and determining the need for specialized burn center care, all of which are fundamental to ABLS principles. The ethical imperative is to provide the highest standard of care based on accurate assessment, directly impacting patient outcomes and resource allocation. An incorrect approach would be to solely focus on the most visibly severe burns, neglecting less obvious but potentially significant areas. This could lead to underestimation of TBSA, inadequate fluid resuscitation, and delayed recognition of deeper burns or associated injuries like inhalation injury or fractures, violating the ABLS principle of comprehensive burn assessment. Another incorrect approach would be to rely on subjective patient reports of pain without objective physical examination to confirm burn depth, potentially misclassifying burns and leading to inappropriate treatment. Failure to systematically examine all body areas, including the back, perineum, and extremities, represents a significant lapse in ABLS protocol adherence, risking missed injuries and inadequate care. Professionals should employ a structured decision-making process that begins with scene safety and primary survey, ABLS, followed by a detailed secondary survey focused on burn assessment. This involves using standardized tools like the Rule of Nines or Lund-Browder chart for TBSA estimation and palpation and visual inspection for burn depth. Crucially, this assessment must be dynamic, with re-evaluation as edema develops. The decision-making framework should prioritize immediate life threats, followed by accurate burn characterization to guide subsequent interventions, always in alignment with ABLS guidelines. Question 18. The monitoring system demonstrates a patient with a significant partial thickness burn exhibiting visible debris in areas of non-viable tissue. The patient is expressing considerable pain and requesting immediate relief. The clinical team is considering the next steps in wound care. Which of the following actions best aligns with advanced burn life support ABLS principles for wound management in this scenario? Option A. Cleanse the wound superficially with saline and apply a hydrocolloid dressing to promote a moist healing environment without extensive debridement. Option B. Administer a sedative to ensure patient immobility and then proceed with dressing application without immediate debridement. Option C. Apply a sterile, non-adherent dressing immediately to minimize further pain and discomfort, deferring debridement until the patient is more comfortable. Option D. Administer appropriate analgesia, and then proceed with thorough wound cleansing and debridement before selecting and applying an appropriate dressing. The correct answer is D. Administer appropriate analgesia, and then proceed with thorough wound cleansing and debridement before selecting and applying an appropriate dressing. Explanation. This scenario presents a professional challenge due to the inherent tension between patient comfort and optimal wound healing, particularly in the context of burn care where pain management is a significant concern. The ethical imperative to alleviate suffering must be balanced with the clinical necessity of effective wound management to prevent infection and promote tissue regeneration. The ABLS certification emphasizes evidence-based practices and patient-centered care, requiring a nuanced approach that considers both immediate needs and long-term outcomes. The correct approach prioritizes a thorough cleansing and debridement of the burn wound before applying a dressing. This aligns with ABLS principles that stress the importance of removing non-viable tissue and contaminants to create a clean wound bed conducive to healing and to minimize the risk of infection. Proper debridement, even if uncomfortable, is a critical step in preventing complications and ensuring the best possible functional and aesthetic outcome. The selection of an appropriate dressing then serves to protect the debrided wound, maintain a moist environment, and manage exudate, further supporting the healing process. This approach reflects best professional practice by adhering to established wound care protocols designed to optimize patient recovery and minimize morbidity, consistent with the standards of care expected in burn management. An incorrect approach that bypasses thorough cleansing and debridement in favor of immediate dressing application, despite visible debris and non-viable tissue, represents a significant ethical and professional failure. This would violate the fundamental principles of wound care taught in ABLS, potentially leading to delayed healing, increased infection risk, and the need for more aggressive interventions later. Ethically, it prioritizes immediate, albeit temporary, comfort over the patient's long-term well-being and optimal recovery. Another incorrect approach, such as using an inappropriate dressing that adheres to the wound bed or fails to manage exudate effectively, would also compromise healing and increase the risk of complications, demonstrating a lack of clinical judgment and adherence to best practices. Professional decision-making in such situations requires a systematic assessment of the wound, consideration of the patient's overall condition and pain tolerance, and the application of evidence-based wound care principles. It involves open communication with the patient about the necessity of certain procedures for their recovery, even if they cause temporary discomfort, and employing strategies to mitigate that discomfort. The decision-making process should always be guided by the goal of achieving the best possible patient outcome, adhering to established protocols, and upholding ethical obligations to provide competent and compassionate care. Question 19. System analysis indicates that a 45-year-old male patient has sustained a 30% TBSA deep partial thickness burn. He is hemodynamically stable and has been admitted to the burn unit. Considering the immediate hypermetabolic response characteristic of such injuries, which of the following represents the most appropriate initial nutritional management strategy according to advanced burn life support principles? Option A. Wait for the patient to demonstrate signs of hunger before initiating any oral or enteral feeding. Option B. Administer parenteral nutrition immediately, as enteral feeding is not indicated in the acute phase of burn injury. Option C. Provide a standard hospital diet, assuming the patient's caloric needs are similar to those of a non-burn patient. Option D. Initiate enteral nutrition within 24 hours, providing adequate calories and protein to meet estimated hypermetabolic needs, and monitor tolerance and adequacy of intake. The correct answer is D. Initiate enteral nutrition within 24 hours, providing adequate calories and protein to meet estimated hypermetabolic needs, and monitor tolerance and adequacy of intake. Explanation. This scenario is professionally challenging because accurately assessing and meeting the hypermetabolic needs of a burn patient requires a nuanced understanding of their physiological state, which can fluctuate significantly. Failure to provide adequate nutrition can lead to impaired wound healing, increased risk of infection, prolonged hospital stays, and increased mortality. Conversely, overfeeding can lead to complications like hyperglycemia and refeeding syndrome. The ABLS certification emphasizes a standardized, evidence-based approach to burn care, including nutritional support, to ensure optimal patient outcomes. A correct approach represents best professional practice because it aligns with the core principles of advanced burn life support, which advocate for early and aggressive nutritional intervention tailored to the individual patient's needs. This involves calculating estimated energy and protein requirements based on the percentage of total body surface area, TBSA, burned, the patient's age, and other factors, and then initiating enteral feeding as soon as possible. This proactive strategy supports wound healing, preserves lean body mass, and modulates the hypermetabolic response, all critical for survival and recovery. Regulatory frameworks and guidelines for burn care, as embodied by ABLS, mandate such evidence-based practices to ensure a high standard of care. An incorrect approach involving delayed initiation of nutritional support fails to address the immediate hypermetabolic state of the burn patient. This delay can lead to catabolism, muscle wasting, and a compromised immune system, directly contravening the ABLS goal of promoting rapid healing and preventing complications. Ethically, it represents a failure to provide timely and appropriate care. Another incorrect approach, focusing solely on standard hospital dietary recommendations without considering the unique metabolic demands of a burn injury, is also professionally unacceptable. Burn patients have significantly elevated caloric and protein needs that far exceed those of non-critically ill patients. Adhering to standard guidelines would result in severe caloric and protein deficits, hindering recovery and increasing morbidity. This demonstrates a lack of specialized knowledge and application of ABLS principles. A third incorrect approach, administering nutrition without regular reassessment and adjustment, ignores the dynamic nature of burn recovery. As the patient's condition changes, so do their nutritional requirements. Failing to monitor and adjust intake can lead to either undernutrition or overfeeding, both of which have detrimental consequences. This lack of ongoing assessment and adaptation is a failure in diligent patient management and a deviation from best practices in critical care. The professional decision-making process for similar situations should involve a systematic assessment of the patient's burn severity, physiological status, and metabolic demands. This includes utilizing validated ABLS protocols for estimating nutritional needs, prioritizing early enteral feeding, and establishing a plan for regular monitoring and adjustment of nutritional support based on patient response, wound healing, and laboratory parameters. Collaboration with a multidisciplinary team, including dietitians and critical care physicians, is essential for optimizing nutritional management. Question 20. During the evaluation of a burn patient, a healthcare provider notes superficial blistering on the extremities and torso. Which of the following approaches is most critical for determining the appropriate initial management and anticipating potential complications? Option A. Immediately estimating the total body surface area (TBSA) of the burn. Option B. Focusing exclusively on the depth of the visible burn. Option C. Inquiring about the specific circumstances and agents involved in the burn injury. Option D. Administering intravenous fluids based solely on the estimated TBSA. The correct answer is A. Immediately estimating the total body surface area (TBSA) of the burn. Explanation. The scenario presents a challenge because the mechanism of burn injury is not immediately obvious, requiring a systematic approach to differentiate between various causes that can significantly impact immediate management and long-term prognosis. Understanding the mechanism is crucial for anticipating associated injuries, such as inhalation injury with flame burns or tissue damage patterns with chemical burns, which are core competencies for ABLS certification. The correct approach represents best professional practice because it prioritizes a thorough history and physical examination to elucidate the mechanism. This aligns with ABLS principles that emphasize a comprehensive assessment to guide appropriate interventions. Identifying the specific mechanism allows for targeted treatment, such as immediate decontamination for chemical burns or airway management for suspected inhalation injury, directly impacting patient outcomes and adhering to established burn care protocols. An incorrect approach that focuses solely on the visible burn size without considering the mechanism is professionally challenging because it risks overlooking critical associated injuries. For example, a small-appearing electrical burn might have significant underlying tissue damage and cardiac dysrhythmias, which would be missed if the mechanism, electrical, is not investigated. This failure to explore the mechanism represents a deviation from best practice and could lead to delayed or inappropriate treatment, potentially violating ethical obligations to provide comprehensive care. Another incorrect approach that assumes a common mechanism without confirmation can lead to misdirected resources and delayed diagnosis of less common but potentially more severe burn types. This lack of thoroughness can be seen as a failure in due diligence and professional responsibility. Professionals should approach such situations by first recognizing that the mechanism of burn injury is a critical determinant of subsequent management. They should then systematically gather information through patient history, if possible, witness accounts, and scene assessment to identify potential mechanisms. This information should be integrated with the physical examination findings to form a differential diagnosis of the burn's cause. Based on this comprehensive assessment, a targeted management plan should be initiated, prioritizing life-saving interventions and addressing any suspected associated injuries.